Moving on to secondary causes of headache. So the one of the most important causes is subarachnoid hemorrhage. Basically, when blood extravasates to subarachnoid space, then the presence of blood activates meningeal nociceptors, leading to extreme headache. About 80% of the non traumatic subarachnoid hemorrhage has an underlying ruptured saccular aneurysm, particularly in the circle of Willis. The risk of subarachnoid increases with age, but there are other risk factors also, like uncontrolled blood pressure, smoking, alcohol intake, etc. So these patients present with sudden severe thunderclap headache. It's sudden onset. That means seconds to minutes. If it takes hours to develop, then it's not really suggestive of subarachnoid hemorrhage. They can have syncope, they can have nausea and vomiting, they can have neck stiffness, photophobia, and seizures. We see that the third cranial nerve is what gets compressed, secondary to an expanding posterior communicating artery aneurysm, causing pupillary dilation. The prognosis is related to Hunt and Hess score. So, this is a classification that is made based on clinically how the patient is, and it helps us in prognosticating them. If they are Hunt and Hess 0, that means the patient has an unruptured aneurysm that is captured on probably incidental CT finding. At 1, they will have minimal headache. At 2, they will have moderate to severe headache. And up until here, we're in the okay zone. Grade 3 is when we start to get really worried, when they will present with drowsiness and confusion. At grade 4, they will be stuporous, and grade 5, they will be in deep coma with even decerebrate posturing. The problem why we get worried grade 3 onwards is if a patient is grade 3, for example, they can very rapidly deteriorate, and grade 4 and 5 generally has a very poor prognosis for the patient even after the appropriate neurosurgical intervention. So that is why when we have a patient that comes in who looks like a subarachnoid hemorrhage or has the features for it, we have to diagnose them with a non contrast enhanced CT head. This should ideally help us identify if there is a subarachnoid hemorrhage and is the imaging modality of choice. If we are suspecting any alternative diagnosis, then performing an LP is not unreasonable. So, if you're thinking about meningitis that is overlapping with subarachnoid hemorrhage features, then we can do an LP, and generally, an LP of a subarachnoid hemorrhage reveals what is known as xanthochromia. And this is what also helps us differentiate between a traumatic LP versus true subarachnoid hemorrhage, whereby in a traumatic LP, by the fourth tube, the number of WBCs should decrease, but in cases of subarachnoid hemorrhage, it's going to be consistently present. But if a patient has a normal CT and a normal LP, that definitely rules out a subarachnoid hemorrhage. As for the management of these patients, remember airway takes priority, especially if the patient is coming with grade 3 subarachnoid hemorrhage that can rapidly deteriorate. As part of their C, we have to look at their blood pressure. We want to keep it ideally in the goal of less than 160 by 130, and we do this by giving them either labetalol, or we can consider starting them on IV nicardipine. The next condition that we need to talk about is giant cell arteritis, which is basically an inflammatory vasculopathy that occurs in medium or large arteries of the body. Generally, it involves all the major branches of aorta and has a predilection for carotid artery. The mean onset of this disorder is around 71-year old, and we see that more women are affected as opposed to the men. Now, most commonly, these patients will come complaining of temporal arteritis and hence a headache that worsens at night and with exposure to cold. They will complain of sharp throbbing or an aching pain, and the pain is going to be localized to their temporal artery with some tenderness. They can have jaw claudication, which is basically vascular insufficiency of the masseter and temporalis muscle, with some systemic signs like fever, weight loss. So, to correctly diagnose somebody with GCA, we need 3 out of 5 conditions to be present. Either they should have age more than 50-year-old and complaining of headache. They should have visual loss or jaw claudication. They should have temporal artery tenderness. Their ESR should be more than 50 or CRP more than 10, and they should have positive imaging finding. As for the diagnosis, so as we said, either we go by this criteria, so we can clearly see either we take history, we do physical examination, we do some labs, we do imaging, and all of it can conclude in diagnosing GCA. Now, how do we manage somebody with GCA? It is sort of an emergency because the most serious complication that these patients have is permanent visual loss that can be preceded by amaurosis fugax. So if somebody is come complaining of visual symptoms, then we have to immediately start them on glucocorticoids, and it has to be very high dose. So something like methylpred 1000 milligrams for 3 days. But if they come complaining of non-visual symptoms, then we can just give them glucocorticoids 40 to 60 milligrams. Now, moving on to intracranial neoplasm. So we know that the most common complaint of this is headache. They can either have a primary neoplasm or they can have a secondary metastatic lesion. These headaches can be either one sided or bilateral, but the location of the tumor is not predicted by the location of the headache. This headache will worsen gradually over weeks to months. It may initially only be present on waking up in the morning, but over time it'll persist during the day. If they will have increased intracranial pressure, then this headache might become bilateral and it might be worse on coughing, sneezing, bending, defecation, and so on. Our diagnostic tool of choice is either CT or MRI, but we know that MRI is not very efficient in emergency department. CT is more efficient, and that too we are going to choose contrast enhanced CT. Management wise, we have to give them urgent referral, and if they have any complications, so they can have increased ICP, they can have seizures, then we manage them in the emergency department. So we manage increase ICP, plus we give them dramatic relief of their headache by dexamethasone. So we give dexamethasone 10 milligrams IV, and this also helps in reducing the edema around the lesion. We can consider giving them NSAIDs, and that also helps in the headache. As for the seizure itself, we can give them, if they're actively seizing, we can give them Keppra, but giving them prophylactic anti-seizure medication if they're not seizing is not really recommended. As for carotid and vertebral artery dissection, It is most common cause of ischemic stroke in people under the age of 50 years, and the reported mechanism is usually neck torsion, chiropractic manipulation, cuffing, minor falls, heavy lifting, and so many more. So let's divide the clinical features based on whether it's a carotid artery dissection or if it is a vertebral artery dissection. In carotid artery dissection, the triad that is described is of unilateral headache, partial Horner syndrome, which comes with basically ipsilateral ptosis and meiosis, and blindness. But this triad is seen in actually very less patients. On the other side, we have vertebral artery dissection that comes with unilateral posterior headache, neurologic deficit, and brainstem ischemia signs and symptoms. So, things like vertigo, vomiting, ataxia, diplopia, hemiparesis, and so on. Any patient that comes with severe retroorbital pain in a healthy patient with no history of cluster headache should be considered to have carotid dissection until proven otherwise. The diagnosis of this is actually done with the help of CT angio, which is 95% sensitive, and it is the appropriate choice of imaging for screening. If we see carotid or vertebral artery dissection on this imaging, then the management for us is thrombolysis, or we can also consider thrombolectomy, whichever is applicable. In cerebral venous thrombosis, the most commonly described risk factor is the same triad that they mentioned to us for DVT, which is stasis of blood, blood vessel abnormality, and hypercoagulable state. But there are other acquired risk factors like pregnancy, malignancy, trauma, surgery, OCP use, and many more. As for their clinical features, they will come with headache that is worsening in intensity over days to weeks, which is the most common presentation. They can also have focal neurological deficit and ocular signs. So, ocular signs like orbital pain, proptosis, chemosis, so on. When we are looking to diagnose somebody with this disorder, we will do full set of blood workup, CBC, UNE, ESR, coagulation screen. If we send for D dimer and they have normal D dimer, then basically the diagnosis of CVT gets ruled out. The best imaging modality for CVT is basically MRI or MRV. It's the one that is most sensitive. As for the management, so if we find that somebody has cerebral venous thrombosis, our job is to anticoagulate them. We can anticoagulate with help of warfarin or unfractionated heparin. We have to anticoagulate them to prevent any propagation of thrombosis and from preventing them from developing embolic complications. This brings us to the end of this lecture.